All right, so PNR 205, exam one. All right, just want to get my stuff up. I don't need that. All right, so I'm going to share my screen. All right, so I have a nice little PowerPoint for this. So exam one is going to be 50 questions. You'll have 75 minutes to complete exam one. So we will run through this PowerPoint. All right, so nursing process. So remember back in week one, talked about the nursing process, who does what. And so assessment, right? The RN does the assessment, LPNs gather data independently. The diagnosis is done by, or the NANDA diagnosis is done by the registered nurse. Planning is done with the RN and LPN collaboratively. Implementation both can carry out orders independently, and evaluation, right? LPNs report back to the RN. So basically, what an RN can do all 5 parts of the nursing process independently, right? They can do the whole ADPI. The 2 parts that the LPNs can do independently, right, is gather your data and implementation. So I forgot what I was going to say. No, it's okay. I'll come back to it because I'll remember it. Again, so the LPN functions in an independent role in the nursing process by collecting data from clients, right, as well as implementing interventions. The RN creates the nursing diagnosis. The LPN collaborates with the RN on the plan of care and evaluation of client outcomes, which of course we know safety is the priority nursing intervention for the client. And so before collaborating on the plan of care with the RN, the LPN must assess the client's understanding first, right? What they know of their condition and what are their priorities for change, right? So we have to understand what our clients' priorities are, what their, what they know about their condition, what they, what willingness are they going to do to make changes, right? In order for them to maintain quality of life, and to potentially, prevent progression of disease. Who does patient teaching? So as an LPN or as a future LPN, can you provide patient teaching?
Reinforcement, but not the initial.
Absolutely correct. So the RN is going to provide the initial education, right? The initial patient teaching, and then the LPN will reinforce as well as collaborate with the RN. So let's say the, RN goes in and provides education, you go in to provide for reinforcement, and, maybe you identify other areas that, the client needs to be educated on, you can bring that back right to the RN and we can collaborate and provide additional education. The U.S. Department of Vocational Education, has anybody heard of this before? This was all the way back in week one. So when we look at the scope of the practical nurse's job by the U.S. Department of Vocational Education, the phrase, the terms that they used were judge, recognize, determine, and appraise. Very similar to what the nursing process is, right? Just different terms. So again, we use judge, recognize, determine, and appraise. That was, the terms that the U.S. Department of Vocational Education used to describe the scope of practice for practical nurses. All right, so collecting data. So we know that there is subjective and there is objective data. So subjective data is something that we obtain from our clients, right? And these are just some example, right? This is my pain. I feel nauseated. I'm hungry. I feel sad today, right? This is something that they tell us. We can't quantify that, right? We can't, put a, put in, we can, well, we can put a number on the pain, but right, we can't really, there's no other way to quantify it other than they're telling us that. Um, Objective information is stuff that, we obtain, we use our senses to obtain that information, right? So vital signs, blood pressure, temperature, pulse, respiration, oxygen saturations, right? That gives us numbers. We can quantify that. Skin turgor, skin color, right? We can see, we can feel. Wound appearance, same thing. Patient level of consciousness, right? We can determine whether they're alert and oriented, they're confused. Um, so we're using our senses, right, to obtain that information. Who else can provide subjective information other than the patients?
Family.
Right? Sometimes a family member, think of a child, right? When we're working with kids, the parents may give us some additional information, caregivers may give us additional information, right? Especially if there's any specific changes from baseline, right? They'll be able to provide us that information. We look at safety, right? We know safety is a huge concern for our patient care and best outcomes. I was telling Stefania before we started this evening about one of my wandering patients that I have, and safety is a huge concern. Um, I'm always afraid that he's going to fall or something is going to happen to him, or he's crawled into beds that are not his. So, and then, I was saying this morning he decided to make a break for the kitchen. I don't know if he was going to go try to cook or if he was just hungry, but we know safety is a huge concern. So lightheadedness, right? We know lightheadedness. I don't know if anybody's ever felt dizzy or lightheaded, right? But it definitely puts us at a safety risk. So establishing fall precautions. What are some fall precautions that we could initiate?
Put the bed at the lowest level.
Bed at the lowest level. What else? Wait, think about, so, okay. What about clear pathways,
Oh,
right?
like removing the rugs and stuff like that, any clutter.
Yeah, clear pathways, making sure that everything is within reach, right? So they have their water, they have their remote control, their telephone, their glasses, make sure that is all within their reach, right? So that they are not trying to, right, reach for something and then potentially fall out of bed. Non-skid socks, assisting in ambulation. What are orthostatic vital signs?
Basically, you watch for the orthostatic hypotension as far as if the blood pressure drops, when they get up, quick movements, you can get dizzy, lightheaded.
Yes. So, right, we're watching for orthostatic hypotension. So, orthostatic vital signs are taking their vital signs in the sitting or the lying, the sitting, and the standing position. All right. So, that's how we would be able to identify that drop in their blood pressure. Um, Post-op patients. All right. So think med surge. We look at safety concerns for our post-op patients. We know pain and vital signs are going to be really important, especially immediately post-op, right? You just had a surgery, you're going to be in some degree of pain, right? So pain control is going to be very important. Um, pneumatic compression devices or even anticoagulants, right? Those are there to, if somebody's post-op surgery, depending on what type of surgery they had, the extent of that surgery is going to determine how much downtime that patient is going to have, right? So one of the key factors is preventing DVTs, right? We don't want to develop any blood clots, right? So that's what the purpose of those pneumatic compression devices are, the anticoagulants. What is the first thing that you should do if you walk into a room and a patient has shortness of breath?
Lift them up, lift the bed up.
Yeah, elevate the head of the bed, right? Say you walk into the patient's room, they're laying flat and they're like, complaining of shortness of breath, or you can physically see them, they're having some shortness of breath. Elevate the head of the bed. That's the first thing that you want to do. Especially after surgery, right? The use of that incentive spirometer. Everybody knows how to use an incentive spirometer, right? That's that thing. You hold on to it, right? You put the mouthpiece in and they suck in and the little yellow ball kind of rises, or some have just like a little disc in there instead of the ball. Deep breathing exercises, even turning, coughing, right? Could be effective in some of our patients, of course, depending. But deep breathing, we want to get that airflow, right? The goal here is to prevent pneumonia and things like that from occurring. Oxygen is always an option as well. All right. So, the LPN will most often reinforce client teaching as well as notice changes, right, needed to the plan of care during the implementation of the nursing process, right? Because the LPNs are going to be the ones that are going to spend the majority of time with the patients. Nursing interventions are patient specific for what the nurse will do to assist the client in reaching goals and identified outcomes, right? So this is where when we write our care plans, right, and we're looking at the interventions, there are some generalized interventions out there, right? But we want to try to gear them individually to our patients, right? And then that will help us to meet their outcomes. Oops. So outcomes. So when we're doing our planning, all right, and we are identifying the outcomes, what kind of outcomes are we looking at identifying? What kind of outcomes should we have? I'm trying to figure out the best way to answer that question. For some reason, it's not coming out the way I need it to. We have two different types of outcomes. Let's try that.
Like them being 100% or at least able to do their ADLs on their own.
Okay, I see what you're saying. You're giving me specific interventions, or I'm not specific interventions, right? But we have short-term and we have long-term outcomes, right? So short-term and long-term goals. So our outcomes should be measurable, realistic, and time specific. So like Margot was saying, right? That, they're going to be at a certain percentage within a certain amount of time, right? So, let's say I have a patient that is post-op surgery and they don't want to use their incentive spirometer, but we need them to use their incentive spirometer. So we'll say that the patient will use their incentive spirometer 10 times an hour, by 3 hours post-op, right? That's time specific, it's measurable, it is realistic, right? Because they really should be using it. But you have to, it's going to be tailored to your patient. So we have to make sure they're measurable, realistic, and they're time specific, right? If you had patient that had a total hip replacement, right? They're not going to be, running a marathon by, week 2 post-op, right? Some patients, I mean, they may within a month or two, but depending on how physically fit they are, right? But we just want to make sure that they are measurable, that they're realistic, that the patient can achieve them with the proper interventions. What happens if a patient doesn't meet their goal? What do we do?
Modify
You
the
go back in and
intervention.
change it.
Reevaluate.
Mhm.
All of the above. We're going to reevaluate, we're going to go and edit it, we're going to change it, look at those interventions and what we need to do to help our patients to meet their goals. Who's the center of the care plan?
Patient.
The patient. And who should we talk with when we're writing the care plan?
The
Same answer.
patient.
There you go.
The tech. Oh.
All right. So, I already, darn it, I'm gonna erase it now that you've already seen it anyway, but so which care plan will provide the most thorough, comprehensive care for the clients?
Individualized.
Individualized.
Very good. The individualized. Don't laugh at me, Stefania. So yes, the individualized care plan. What's a standardized care plan?
Isn't
I
it
feel
something
like
that's gonna be like kind of like customary based around like
like
the diagnosis or
right specific, like basically.
Right.
She
It's
said.
more like your textbook care plan, right? So you go in your textbook and it's got a care plan for heart failure or diabetes or hypertension, right? That's a standardized care plan. The individualized care plan, right? We take that standardized care plan and then we customize it that so that it is specific to our patients.
So it's based off the diagnosis.
Yes.
Okay.
Yep. Not, yes, a lot of them are based off of diagnosis, but you also have to remember too, it's stuff that we identify when we're collecting data, right? So a lot of times we tend to focus on the diagnosis and making those care plans. We also have to take into things like, remember, we have to take into consideration things like spirituality, religion, right? Some of those, the psychological aspects of care as well. So yes, while a lot of it is going to be based off of their physiologic condition, we do have to take some of those other concerns into consideration when we're writing those care plans. So client-centered, relationship-centered care. So providing care that is respectful of and responsive to individual client preferences, needs, and values, and ensuring that client values guide all clinical decisions. And so this is something that we also have to take into consideration, right? How much are they willing to change in order to care for themselves, right? Are they willing to make the diet changes necessary for that newly diagnosed type 2 diabetic or that newly diagnosed hypertensive patient, right? What are their attitudes and their beliefs and values regarding healthcare? We always focus on client care needs, try to include client preferences as much as possible. And we can include client care, or I'm sorry, the client's care preferences as long as it doesn't interrupt care or, potentially cause harm to them, right? Or interrupt care, disturb other patients on the unit. And then the client is given information for informed decision making, right? So when we look at we're looking at establishing plan of care, whether it's for a specific disease or something else, right? We give them the good, the bad, the ugly, right? All of their options for care. and all the, all the good that can happen, all the potential, bad effects that can happen as well. So they have all the information that they need to make that informed decision, right? So think about it. Somebody's, gets a diagnosis of cancer, and we're going to put them on chemotherapy, right? What are some of the, what are the potential side effects of chemotherapy, right? So they get to know everything, have to be taught, told or given all of the information about the treatment options, as well as what alternative treatment options are available to them. So we also talked about communication. Communication was a big topic for us. And so we have different types of questions that we can use. We have closed-ended, questions. We have open-ended questions. Which type of question is going to give us the most amount of information?
Open-ended.
Open-ended.
Open-ended questions, right? Because if I ask you if you have pain, you could simply say yes or no, right? Same thing. Are you hot or cold? I'm hot or I'm cold, right? You're getting very little response, right? But if I ask you to describe your pain or, what do you know about your wound care? What's your morning routine, right? This is generally going to elicit a lot more information. All right. So both of these have a purpose, right? We just tend to use the open, or the open-ended questions, right, to elicit more information. All right, let's talk about SPAR. So situation, background, assessment, recommendation. What are we saying in situation?
Who we
The
are,
purpose for the
issue.
call.
patient,
The reason
chief
for
complaint.
Okay. Yep. So we're gonna tell them who we are, right? The reason for the call. What information are we gonna do in background?
Usually about the patient's like past medical history,
Okay. What about
things that have
assessment?
happened.
What about assessment?
What your thoughts are as far as the nurse, what you think is going on with the patient at that time.
Okay. And you're gonna give concrete, right? You're gonna give vital signs, all of that stuff, and then recommendation, right? What do we think should be done, right? Is it a new treatment? Is it a new medication? Do they need to be sent to a different level of care, right? Those are going to fall into that. So again, situation, what's the reason? Go ahead.
Sorry, I had a question on the SBAR because during the Cahoots we went through a couple different ways, which I'm glad we did. But when it comes to the background, I wanted to know, like, I don't know if we'll get that kind of question, but more so for real life, future reference. When it comes to background, I understand like you're you're given that information, the background, the current status on the patient. What happens if, like, say you're calling the provider again? Is your background changing based on like what happened currently, or are you just skipping over that? There's no need, of course, to give it.
So let's say I call the provider. Let's say my patient fell and hit his head. Okay. So, right, I'm gonna say, hey, Dr. Jones, this is Jennifer. I'm calling from, such and such a place. I'm calling regarding Mr. Jones. He fell and he hit his head. All right, so then my background information, he was admitted on what's today, July 27th, for diagnosis of encephalopathy with altered mental status. Here's his vital signs. Here's his code status, here's his current medications. And then I'm going to say, with the assessment part, what do I think is going on? Honestly, in my situation, I'm going to say the client is confused, he's disoriented, he was unsteady on his feet, went to sit down on the toilet, slipped off the toilet, and hit his head. All right. Um, not life threatening, however, right? He is an elderly client, which if he did hit his head, right, he could have a bleed. So recommendations, I would I think maybe that he needs to be sent to the hospital, potentially to get like a CT scan or something along those lines, right? I would recommend that he needed to go to a different level of care. If I had, let's just say the doctor disagreed, okay, and said, no, let's just monitor on site. Okay, so I'm going to monitor him. If I have to call the provider back, I'm going to do it all over again. Like I'm going to tell him, look, we already talked, I've been monitoring him. We're getting we have a decline in mental status, whatever the change may be. Then, again, I'm going to recommend that he go to a different level of care, right? So the best way to do it is just to stay with the SBAR and just provide even if it's redundant, just to provide that information. Because you have to remember, we are with our patients, right? We are on shift, and depending on where you're working, you can have like six patients in a hospital, or in my situation, you can have 26 patients on a skilled rehab unit, okay? That doctor, right, may have 150 patients, 300 patients. And so whereas, we always think that ours is the most important, right? He may not remember, the whole situation from the last call. So that's why I always just go through it. Even if he does, he can stop me if he does, or, I'll just keep going. Um, so when we use SBAR for change of shift, it's going to be a little bit different. And this I'm going to say too with SBAR, it's going to be different where you're working as well, because if I used SBAR where I work, a change of shift report would probably take us an hour and a half. In a hospital setting, this is very effective. So you're going to give them the admission date, the chief complaint, the diagnosis, right? So patient was admitted on 7/27. He came in complaining of, let's say, shortness of breath, right? And then the admitting diagnosis was pneumonia, right? Background, medical history, allergies, code status, lab results, IV lines, diet, mobility, pain management, response to interventions. That's in your background. What we would focus on was like, what's the medical history that is going to be the most pertinent, right? I don't need to know that, he had his gallbladder removed, 20 years ago, right? Because that's not necessarily pertinent to this admission. Allergies, code status, lab results, those are going to be more pertinent. And then the vital signs, pain, do they have any diagnostic studies? What measures are in place, fall risk, that kind of thing. And then the recommendations, the goal of care, what needs to be done, what education needs to be provided, their discharge needs. Oops. All right. So still more on communication, because like I said, communication was a big part of this. Especially week 1 and 2. Active listening. Active listening is the most important part of communication, especially when we're looking at establishing or performing therapeutic communication with our clients. And it focuses on their physical and emotional needs. And so we have to have really good, effective communication strategies, right, in order to support our clients. So key factors in active listening, the purpose, right? What's the reason for gathering data or giving information? disciplined attention, right? So this, do not assume accuracy of information without checking it out. So you want to clarify what you think you understand the client is saying, right? This is really important because how many of us, when we're listening to someone talk, start writing grocery lists in our head or thinking of, oh my God, I really got to get to Mrs. Jones' room because I told her I'd be back and Mr. Smith won't stop talking, right? Um, so it's really about disciplined attention, right? Being in the moment with that client. So you want to focus all of your senses, make, any clue that your client is giving, right? We're looking at the verbal, the not and the matching with the nonverbal. We're looking at body posture, facial expressions, right? All of that stuff. Um, a common mistake is listening is listening to the words but not hearing the words, right? Again, we may start making grocery lists in our head, or we're really thinking about like, I got to get to so and so's room, or oh my gosh, I forgot to put this order in, or I got to go give this medication. We really have to focus on the client that we are with at that time. So active listening techniques. So we went through these. Restating, right? Repeating what the patient said in a slightly different way. Again, patient tells you I have a headache, so what I hear you telling me is your head hurts. Okay. So you said it in just a slightly different way. Clarifying is asking questions in response to a patient's statements, and that's just to make sure that you understand, or you make sure that you understand what the patient said. Reflecting is putting into words the information you receive from the patient. Paraphrasing is expressing in your own words what you think the patient means. Minimal encouraging, right? That's the patient's telling a story and you want that to continue. So you're like, okay, tell me more. Sure. Really, right? You're just using those words to kind of keep the conversation going. Silence is, like I said in lecture, silence is something that a lot of people have, are uncomfortable with. But silence does have that purpose. Variety of persons just, or a lot variety of purposes, if even just to give somebody a chance to regroup their thoughts, right? And kind of think about how they want to answer, or to make sure that they understand the question and they just want to, make sure they answer it appropriately. And this is something a lot of us, I know I do, have to work on, is just knowing that silence is something that is okay. Summarizing is saying the data you've gathered, and then validating allows the patient to correct information when you're summarized, right? So patient gives you a bunch of information and you summarize it back to that patient. That gives them a chance to say, oh no, I didn't hit my head when I fell off the toilet. It was actually when I bent over to pick up my sock off the floor, I hit my head on the sink, right? So whatever, it just gives them a time to make sure that, you heard what they said, you repeated it back to them, and then that gives them a chance to just make sure that everything is correct.
Can I ask a question?
Yes.
On the exam, they're not going to want to know, like, they're not going to give us, oh, here we go. What's the difference between, I don't know the difference between restating, reflecting, and paraphrasing because they all sound the same to me.
They all do very much sound the same. But well, and we're going to go through them again. So when we look at, it's going to be just mainly understanding how to, what's the word I'm looking for? It's just understanding, right? Like if somebody were to say, if someone said to you, I think that you misunderstood what I said, which one of those would that be?
It'll be clarified, but
Yeah,
or
clarifying.
validating, or
Yeah,
validating, right? Because they're saying to
if you
yeah,
understood.
very good. So again, clarifying is asking closed-ended questions in response to a patient statement to be sure you understand. So if the patient says their chest hurts, all right, you're going to ask, tell me exactly where your chest hurts, right? Whether you tell me, you point to it, right? Show me exactly where your chest hurts. So it's clarifying. So we're asking questions to get more information. With restating, we're repeating what the patient said just a slightly different way. So they said that my chest hurts and I can't sleep at night. So the nurse responds with, you have been unable to sleep at night because your chest hurts. Okay. So you're taking that information, you're just repeating it back to them in a different way. With paraphrasing, I mean, it's kind of very similar as well, right? This is your own words. Okay. So the patient says, I don't think I'm being told the truth about my condition. And then the nurse replies, you believe you have not received all the important information about your health condition. Right. So you're just kind of, they're very similar. We're not going, I don't think we're going to ask you to clarify between the two. All right. It's just understanding the different concepts that are out there, but you're absolutely correct. They're all very similar. But basically what this is telling our patients, right, is that we're listening to them, right? We're hearing what they're saying. And that's really the purpose of it. However you do it, whether you clarify, whether you paraphrase, whether you restate, right? It's all showing that we are listening to our patients. Oops. All right, positive communication techniques. Develop trust through openness, honesty, integrity, and dependability, right? This is something that I'm sure you've taught or you've learned from day one in nursing school, right? Open, honest communication is going to be the key to success. Using iMessages. iMessages kind of take, we take ownership of what we're saying rather than throwing our feelings on somebody else to, and because that can, lead them to be defensive, right? So like my wonderful wandering patient, I could say, I feel uncomfortable when you're wandering the unit and crawling in and out of other people's beds all night. Okay. Not that he would understand, but I'm just saying, it would be an I statement, right? So that, we're not causing anybody to become defensive. Establishing eye contact. Eye contact is absolutely necessary. As we do need to establish eye contact that, helps to promote trust. We do have to take into consideration cultural differences, right, with eye contact as well, right? But we do establish eye contact. Keep promises. Keep promises. I can't tell you how important this is. If you tell a patient that you're going to be back in 5 minutes, you better be back in 5 minutes, right? Even if you go back in 5 minutes to say, hey, Mr. Jones, I know I said I'd be back in 5 minutes, but I really have something important that I need, I hate to say important. I really have something I need to do. If you could just give me a few more minutes, then I'll be back as soon as I'm done, right? At least you met that 5 minutes, right? Even though you couldn't spend this time with them then, but you gave them another time frame. Empathy. What's the difference between empathy and sympathy?
Empathy, you understand their feelings, and sympathy, you feel their feelings.
Right. And empathy, right? We can, exactly, we can understand what they're going through, right? But we never really truly know what anybody is going through, right? Because you can have two patients in very, similar circumstances that are going to experience it two different ways. Use your open communication, get your clarifying information, and be aware of body language. Not just your body language, right? But the body language of our patients as well, because they need to be congruent, they need to match. And so we need to really pay attention so that we don't overlook or miss anything. Things that affect communication, personal characteristics, things like age, gender, income, life experiences, the cultural characteristics like personal space, language, values. I'm going to throw eye contact in there as well because that will often fall under a cultural characteristic. Situational influences, which is your environmental noise, physical or emotional state, odors, distractions, right? Go into a patient's room and the television's on 100, right? You're not going to be able to have a conversation, right? They're not going to hear you. You're not going to hear them. You're going to end up shouting, and it's just not a good situation. Um, Physical and emotional state, if somebody is very, very upset, um, they may not be open to communication. They may just need that moment of silence, your presence, until they're, in a better state emotionally. Foul odors, um, things like that are also very distracting. And if there's like, think about it, people coming in and out of your room, or if you're in a room and you're talking to a client and somebody, is coming in trying to pull you out of the room, or your little phone is ringing, whatever it is, those are all distractors that can affect the communication that you have with your patient. Negative communication or in blocks, right? Generalized answers, false reassurances, oh, like everything's gonna be okay, right? Um, Probing, judging, belittling. Why don't we give advice? Why don't we give advice?
It might go wrong and they'll look at us for answers.
It might go wrong, absolutely. Um, we don't give advice. And you're right, because it can go wrong. But generally speaking, don't give advice. If something that the doctor says, that's one thing, but don't say if it were me, or if I was in this situation, this is what I would do, right? We avoid those at all costs. Because let's say they decide to do it, it doesn't work, right? Who's it coming back on? Well, the nurse told me that, this worked for, yeah, so we don't do it. All right. So tell me about non-assertive passive behavior style.
Not wanting to answer questions or deflecting it to like, well, you'll have to ask the RN, or you'll have to ask the doctor, like just not being able to answer.
Not being able to answer. Very good. Tell me about aggressive.
Just
Maybe
being
you're saying or you're saying something like in a loud tone. You might be using a lot of negative body language, pointing, poking the air.
Okay. Um, I forgot what I was going to say. Oh, what about assertive?
a more professional manner. Like you said,
Okay.
using I a lot too as well.
Okay. So which is the best? Your
Assertive.
best?
Assertive.
Assertive, right? Um, do we want to be aggressive? Would there be a time where we would need to be aggressive?
During a cold, if everybody's standing around.
Okay, I like the way you said that. During COVID, when everybody is standing around. Um, so I'm trying to think of the best way to say this. Um, what's the best way to say it? So my brain is like, um, so when you need to be more, what's the word? Directing, I guess, right? Is that what you're saying? Like when you said during the code, like everybody's just standing around, right? Um, it's, but it's more, you can still be assertive, I think, without being aggressive. Um, and I know what you're saying, and I think that's like when you're like it's more of a like when people are standing around and things like that, it's more of a frustration, right? Like just get up and do what you need to be doing. Which I can understand, trust me, as long as I've been in healthcare, I can totally understand. But yeah, so we want to try to move more towards an assertive behavior than we would an aggressive behavior. But Margot, I totally understand where you're coming from. Um, so yeah. And so we try to be assertive. Assertive is kind of, you being able to, um, say what you need to say. You are using those, I, those I statements as well. A lot of people have trouble being assertive. You have to be, stick up for yourself, right? Stick up for your rights as well as advocate for your patients, right? All through that assertiveness. Um, oops. So, right, assertive, they're going to be more likely to advocate for their patients. Um, I- your passive are going to be more likely to pass the buck. And then your confrontational is going to be more of your aggressive behaviors. All right. So workplace violence. Unfortunately, healthcare, we are not immune from workplace violence, which, is sad considering the job that we have to do, right? We are still going to be at risk for that workplace violence. So things that contribute to the risk for workplace violence, the location of the city or the location of the facility, right? Are we in an inner city? Are we in a rural area? Um, failure to provide a secure area or security personnel. All right. So does the hospital have security? Figure mostly in the emergency rooms. And I'm not saying emergency rooms are the only place that we could potentially experience violence, right? But that's where the majority of our patients come through, right? Is the emergency room. So making sure that we have a good security presence. The client, are they under the influence of drug or alcohol? Do they have mental health illness? Are they already combative? Have they had a head injury? So head injuries have the potential, right, to cause personality changes where you may have had a very calm, person in normal everyday life that suffers a head injury, right, can now become combative and aggressive, right? So these are some of the things that increase that risk for violence in the workplace. Sexual harassment. So that's, when you, unfortunately, this is something that could potentially be an issue, depending on, the situation. But sexual harassment is an abuse of power. All right. It's not about sex. It's not about passion. It is about abuse of power. And so if you are the victim of sexual harassment, the first thing that you do is confront that person. Um, you confront the person, be very assertive. You tell them that the behavior is offensive, right? And that it is unwanted. Um, you want to make sure that you are very assertive, not aggressive, all right, and that your verbal and your nonverbal behavior match. And then document, what happened. If it does not stop, right, then we report it, right? You do not let it go because employers have the responsibility to correct unwanted behavior that they know about. And so if an unwanted behavior doesn't cease, you report it to your supervisor, your HR, whoever it is. And then, you keep going from there. All right. Cultural skills. So cultural competence. Cultural competence is the continuous attempt to gain knowledge and skills that allow you to be to effectively provide care for clients of different cultures. Cultural sensitivity is the awareness of different cultures. Cultural diversity is the differences in the elements of culture and groups of people. And we know that we are very culturally diverse here in the United States. Enculturation is the process of learning your culture, right? The way your group does things. So when we look at cultural diversity, areas to consider: client preferences, client needs, values, right? Language barriers is often one thing. What do we do if we have a client that does not speak our language?
Contact an interpreter.
Get an interpreter.
Oh,
Absolutely, 100%, right? Um,
not the family.
right, not the family. I forgot what I was gonna say. But yes, interpreters, 100%. There also have to be cognizant of nonverbal behaviors, right? I said earlier, like eye contact, right? Some cultures are very uncomfortable with eye contact, or they won't maintain eye contact. Other cultures are very big on eye contact. Touching, right? Some cultures are very stoic. They don't want you to touch them. Other cultures are very hands-on, right? They like to put your hand on your shoulder. They may want to hold your hand, right? They may be huggers, right? So it's, different cultures are going to have different expressions. That goes to space as well. Some people, don't are comfortable being in a small, having a smaller distance between them. Others prefer long, wider differences. Again, this is all things you can get a basic understanding of what some of the generic cultural differences are, right? Just by like doing research. And then you can get more specific as you interact with patients of different cultures, right? You can, ask questions, right? Learn about their culture from their standpoint. There's also food preferences, what they eat, when they eat, how they eat. Um, you know, are they, people that get up at 6 o'clock in the morning and they expect breakfast at 6:15? Or are they people that, just kind of wake up when they wake up and then they expect breakfast? So like maybe I'll wake up at 9 a.m. and I want breakfast at 9:30, right? What are the different, different variations there? Food preferences as well, right? So of course, the biggest one that comes to mind, we have our Muslim population, right? No pork. The Jewish population, they, kosher versus non-kosher. And I actually did research into that, and that just blows my mind. I would probably mess that up in a heartbeat if I ever tried to do that, because they have like separate, like they have like kosher, like everything is separate, right? They have like separate pans for dairy and then separate pans for meat. Like it's very like segregated. It's very interesting and
They
fascinating.
even have separate sinks. I was at my boss's house years ago and I started washing the meat dishes with the dairy sponge in the dairy sink
Oh no,
and
no.
contaminated an entire thing of plates. I didn't know, but it is. It's very
Yeah, I mean, if you grew up with it, obviously it's like second nature, but for me, I'll be like, oh no, like I'm gonna mess this up. So yeah, so culture is a big part of it. Um, Negative effects on culture, stereotyping, right? That's the assumption used to describe all members of a specific group, right? Ethnocentrism, is the belief that a cultural group's way of thinking or view or way of doing things is superior, right? Prejudice is an intolerance of another culture. And then discrimination is withholding rights or privileges of another cultural group. And then we have our wonderful IDT, which is our interdisciplinary healthcare team, which is the group of professionals, right, that contribute to the care and the treatment of a client. Um, and so depending on where you work, is going to determine who is going to be on your care team. So for example, long-term care, I work rehab. So we have physical therapists, occupational therapists, we have dietary, we have social work, we have activities, we have nursing, right? And then, in a hospital, all of the same, right? But then you also may have like respiratory therapy, you may have a case manager, in addition to that social worker, right? So it is a group of people, they are all going to contribute to the care and treatment of a specific client, and they will all have, specific, um, interventions and implementations that they will perform in conjunction with that client. Um, all right, and so other things to consider. Um, the nurse must accept the client's right to their belief and neither agree nor disagree with their choice and respect the right to refuse treatment or medication. We do not try to change their mind. We do provide education as to why they should not refuse a specific medication or a specific treatment, right? We provide that education. Um, if a client asks you to pray with them or perform a baptism, what will you do?
Pray with them or perform baptism.
Yep, you're gonna pray with them and you will perform that baptism. Um, some clients also may belong to a religion that does not believe in certain medical treatments. Never assume what a client's choice will be. Offer them the choice and let them make the decision. And I have firsthand of that. I had a client way back when I first started nursing, as an LPN, who was a Jehovah Witness, who had a hemoglobin of like 4.9. It was crazy low. The doctor wanted him to have a blood transfusion. The family said no, but he was his own responsible party. And he said, heck yeah, I want that blood transfusion. Okay. So we sent him to the hospital so he could get his blood transfusion, right? So just because he was a Jehovah's Witness, he wanted the blood transfusion. He understood the risk versus the benefits. And he chose to get the blood transfusion because it was going to bring his hemoglobin up faster, right, than just traditional treatment. Clients may also have different food preferences or times to eat. So that's why I was saying, like, depending on your time orientation. If I wake up at 9 o'clock, I don't want that 7 a.m. breakfast that's been sitting at my bedside, right? I want my breakfast to do, after I wake up. Um, and so hospitals do kind of accommodate this a lot better than a long-term care facility would. So that is some stuff that we can take into consider and make changes. But I just thought it was really interesting. I have heard and actually have seen, people perform, what do you call it, baptisms, like on especially babies, that may not make it right after birth. And so it is something that especially Catholics, are very, very particular about. So, all right. So that is my exam 1 review. Does anybody have any questions?
Thank you. Don't
Yeah.
be so.
All right, you're very welcome. I will